Holding your elbows in tight.
Good job, man.
That's cool.
Yep. A little more. There we go. Got it. So palpate it again with your finger.
Huh.
So it should feel some decreased tone there.
Yeah.
What's going on out there in YouTube land? Today we are with one of the best orthopedic surgeons, sports medicine specialists in the country, Dr. David Abbasi. He's got a huge YouTube channel that's going out there. He's got all kinds of interesting videos, particularly around sports injuries. So if you guys are MMA fans, boxing fans, NFL fans, and you see somebody get hurt, you're wondering what's going on, this man right here breaks it down to the T, makes it easy for you guys to understand. Make sure you go over there and subscribe. I'm gonna put his link down here below. Super interesting content. So he's down in South Florida. He takes care of a ton of MMA fighters. He's an MMA fan. He also does octagon ring stuff. So he's the sports physician for the actual fights. He does Titan. He's done the UFC events. So this guy really knows what he's talking about, what he's doing when it comes to the MMA game. So when guys have injuries, they come and see him and he takes care of them. So we're gonna work on him a little bit today. He's got just some tightness, a lot of stuff from just being in the OR and filling out lots of notes and all that other kind of stuff. Yeah. But all in all, pretty healthy. You ready to rock and roll?
Let's do it.
Let's do it. So tell me, what got you in MMA? Were you in med school? What really sparked your interest in wanting to deal with the MMA community?
So back in high school, I used to wrestle. So I wrestled for 4 years and then actually went to University of Iowa for college. I did not wrestle there, obviously. I would have been a Raggedy Ann doll, but after that, so then when I was a doctor, I was doing a lot of like lifting weights and stuff, and I was just kind of getting bored. So I was actually looking at getting back into like wrestling and stuff just or like helping a high school out. And then somebody got me onto doing Brazilian Jiu-Jitsu. So then I started doing Brazilian Jiu-Jitsu. So I did a couple years of that. And that, I would say, really kind of escalated my interest in the UFC and MMA. But I mean, I was one of those guys that was like, when I was a kid, I was like going to Blockbuster and renting like UFC 1.
Okay.
Like watching Hoist Gracie and stuff like that. So I've always had interest in it for sure.
Interesting. So did you always want to be a physician, or what led you down that road?
While I was in college, I thought I wanted to be a pharmacist because we didn't have any doctors or anything like that in our family. But
so you're the first.
I was the first, yeah. My parents immigrated from Iran, so like, to be honest with you, I didn't think that was even a possibility. I didn't know any doctors, didn't have any mentors. And at the University of Iowa, I thought I was going to be a pharmacist, and then had this like crazy burn injury just working in the pharmacy, and then had an experience in the hospital that made me kind of turn into medicine, liking science, liking anatomy, and then loving sports. Orthopedic surgery was just the perfect fit.
So what'd you major in college?
So I was going to be pre-pharmacy, but then when I decided to make the switch, I actually had a major in psychology because it was going to be the only way I could graduate in 4 years.
Okay.
Yeah.
And then you went to med school in Chicago, Loyola? Correct?
Yeah, so I went to Loyola for med school back home.
Okay.
And then went to University of Cincinnati for residency, which is 5 years. And then I came down to Miami for sports medicine fellowship. So if you add all the schooling I've had in my life, I graduated the 26th grade.
So 14 years essentially of college level education. Okay. It's a lot of schooling, man.
Yeah.
Surprised that brain even fits in this thing.
Yeah, right.
But you were a professor too, right?
So I was when I was at Texas, I was with the University of Houston, or University of Texas in Houston, where I was an assistant professor.
And that was helping orthopedic surgery residents?
Residents and the physical therapists and things that would rotate through with the affiliation.
And so what kind of surgery do you specialize in, generally speaking?
So I'm an orthopedic sports medicine specialist. So basically 95% of what I do is arthroscopic surgery, mostly of the shoulder and of the knee, the majority, and some elbow as well. And then, doing sports medicine and taking care of a bunch of these UFC guys, you kind of got to know a little bit of everything because they get some rib stuff, they get some ankle stuff, they get a little bit of everything. But from a surgical standpoint, definitely a lot of arthroscopic shoulder and knee.
Okay. So your hand-eye coordination is top-notch.
It's okay.
So that means you can't be punching the bag that hard, man. You can mess up those hands.
Yeah, I hope not.
Right there, feel kind of tight?
Oh, yeah.
So you work with some of the Sanford athletes, American Top Team.
Mm-hmm.
You deal with a lot of athletes in the Miami area, correct?
I mean, South Florida, and that's literally the reason why I moved down to South Florida, is one day I was just like, man, I want to take care of the best fighters in the world. And so it was kind of on a whim, but man, I'm really glad I took that risk, the calculated risk, and moved down here and just kind of got involved with the community, got involved with the gyms, introduced myself, let the world know who you are, let them know what you want to do, how you can add value to them, and, good things can happen. So I've been very very happy, very blessed about that. And helping these guys kind of reach their maximum potential has been really cool.
Awesome. Yeah, my buddy Steve Mora, he's kind of the West Coast version of you.
I know Steve.
Yeah, Steve's
I know
awesome.
Steve. So we message a lot on Instagram. Yeah, he does really good stuff out there.
He's a knee shoulder guy.
Yeah, me
Just
and him
about
do the
most
exact
of
same
it.
thing.
Yeah.
Yeah.
That's why I said you're the East Coast, he's the West Coast
That's
versions.
right. We've actually messaged about that.
No, we've sent a few folks out to him as well.
Yeah.
One of my fighters, Jody Escobar, she had an ulnar fracture, and he did a really good job taking care of her. And
Yeah.
so we co-manage quite a few patients.
That's cool.
Is that starting to fade?
Yeah. Are you pressing it as hard as
Yeah.
before? You are?
Yeah.
Oh, it doesn't feel that way.
All right, let's look straight down, and then bring your head back up, and then go straight down, and back up, and straight down. So think about so pressure, right? So force is mass times acceleration, pressure is that over square area. So if I'm pressing on a muscle and it's eliciting a pain response, as the muscle relaxes, which is kind of an opposite of a GTO reflex, it'll elongate, and there's less of those nerve fibers underneath my thumb, so it doesn't hurt as bad. There's probably a little bit of plastic change too, just getting accustomated to it as well. Yeah, we were just talking like the irony about the Anderson Silva tib fib fracture.
Oh, that's crazy.
Did you think that Chris Weidman's was open?
You know what? I didn't.
Couldn't
I
tell?
don't know. I mean, what's the fine? I don't know if it was. Was it? Because there's this like very
Steve seemed to
tricky
think that it
picture.
was.
I know, I see that, but if you look at it closely, I think it might be like a
Just an
skin
indention
crease.
of-
I think it's a skin crease.
That's kind of what I thought too.
Because I feel like if it was open, they'd be making a much bigger deal
bigger
about
deal,
it.
yeah.
Much bigger deal about it.
Because it's
yeah.
obviously much more serious when that happens.
Right, much more serious, yeah. And here's the other thing that kind of clues us that probably it was not open is they said that he was going to be stabilized overnight and then taken in the operating room in the morning.
They would have operated immediately.
I think, the literature shows that that's okay to do, but in a guy like Chris Weidman, I don't see a lot of orthopedic surgeons waiting overnight. So if it was open, I think most likely he'd be gone in the operating room that
Immediately.
night for sure.
Yeah, that makes sense.
So I actually talked about this on my breakdown video on this injury, but so the procedure for those tibia fractures is we stabilize it by placing a nail within the bone. And so, some people don't know that the bones are actually hollow. They're not completely made out of bone, and that's where bone marrow is made. So we have room in there to place things to stabilize it. So what we do is we actually make an incision in the knee, we split the patellar tendon, and then go down and access the top of the tibia bone, and then slide a rod down in it after we realign the bone, and then fix it with screws that are crossing the bone that interlace within the nail and then on the other side of the bone. So basically after that bone is rock solid.
Yeah.
And as long as that we can get that bone in the right position as we're fixing it, literally the next day you can allow them to start walking on it. And I think he released a follow-up video today that he might have been walking with physical therapy,
Right.
which is great to see.
And generally speaking, what we've learned over the last 15, 20 years is the quicker you can get you loading, these types of surgical injuries, generally speaking, the better the outcomes are.
Right, because you will start to get like really rapid atrophy of the muscles after surgery. So we want to start getting you back to normal as quickly as possible.
Yeah, and that's actually what happens a lot of time with adhesive issues anywhere. So, anytime you have an injury, if you've ever had a cast on and you take it off after 4 weeks, it's almost impossible to move your wrist, your elbow. So just in that amount of time, the collagen changes, the stiffness in the joint, the amount of hyaluronic acid that's moving around, it gets very stiff very quickly. So the same thing can happen on people that chronically don't move. That's why we always say, motion is lotion. So you've got to make sure that all joints move fluidly if you're going to be a healthy individual.
Right.
And then also to heal we respond to gravity, we respond to stress and stimulation. If you're not doing that, your body responds very quickly, like in, astronauts, they lose bone density
Just like
almost
that,
instantaneously.
right.
Yeah, and muscle atrophy
Yeah.
can happen in 2 weeks.
Right.
So
Even sooner, yeah.
Yeah,
I
yeah.
usually see patients at doing just a simple knee scope, 2 little 1 centimeter incisions at the 1 week follow up from the operation, from the little arthroscopic cleanup. They already have quad atrophy. So
yeah, so shout out to all the docs that are getting everybody moving right away, like Doc here, and all the PTs that are really getting into work and quickly. So making a big difference in these people's lives. So let's hold your head right there. Look straight down. Tuck your chin down to your chest. And bring it back up. And then go back down again. And I know if you guys don't want to throw up, don't Google Chris Weidman leg injury, because my wife is having the aversion to it as well. And then I kept forcing her to see it again. Take a look. See, this stuff, I'm sure it doesn't bother you at all, right?
not at all.
Yeah, same.
No, I was your very first year of orthopedic surgery residency. You get very, very used to that because you're getting called down to the emergency room and you see a dozen of those a day and you're straightening them out. You're you're putting splints on, and then the next day you're fixing them in the operating room.
Yeah. And even for me, just, going through cadaver lab during grad school, you just get used to seeing parts, opened up and moving, and stuff just doesn't bother you anymore. And I'm in an MMA gym, so we're kind of the first line, so they'll bring us up to them and we go, hey, this is something I think we can fix, or they need to go across the street to the hospital. So we sort of get to make the decision on the spot if we need to get x-rays, if we need imaging, or we think it's something more conservative. And we kind of work hand in hand with the coaches to decide where they go to next. So a lot of responsibility, but for the most part of the years, we've been able to work really well hand in hand with both our orthopedic surgeons, physiatrists and our PTs as well. So it's an interesting game when you're working in a team environment like that, making sure that everybody gets the right care, because everything works for what it's supposed to. And if you try to put the wrong treatment for the wrong therapy, you're going to have bad outcomes.
Yeah, teamwork is so important.
Is that pressure there?
It's okay.
Feels okay?
Yeah.
Let's compare that to this side. How's that feel comparatively?
Does this side feel more awkward than the other side?
A little bit.
Yeah.
He said
Yeah, I gotta
awkward.
work on my posture.
All right, let's go and lay on your back. All right, let's go ahead and turn your head to the right all the way, and then go back to the center, and back to the right. So when you're doing your sports medicine fellowship, how much does that differentiate with your training that you've had in orthopedic?
So in residency, there's the thing about orthopedics now is like there's so many.
Because family docs
subspecialties,
also
yeah.
do sports medicine, right?
Yeah, so there's like operative and then there's non-operative. So like family medicine or emergency room docs, they also can do sports medicine fellowships. That's really helpful for, they can make all the diagnoses and things like that.
And they're casting and
They're casting, they can do
injections.
injections, and really just like I would say musculoskeletal medicine versus like general medicine, like, looking at the heart or lungs. It's really kind of like, if you don't have, a lot of doctors are not great at it, to be honest with you. They're very good at the heart, the lungs, and labs and things like that, but not very comfortable with the musculoskeletal. So it's almost like its own type of medicine. Doing the non-surgical can be very helpful, that they can maintain the musculoskeletal side, and then they get, some get special training in concussion, which is getting, very, very, big right now.
Absolutely. Take this hand and reach down towards your foot with it. So you can go down like that. Little pec minor. Okay, and shrug back up. And reach down. Because I always said that the Anderson Silva is like the iconic MMA injury.
The tibia?
Yeah, the tib fib. But, Weidman, I think that tells us we have to be living in a simulation.
So that was...
Like the odds of it happening to him after checking the kick previously.
Do I have any simulation books over there?
I think there's been 3 in the history of any major promotions.
So basically Uriah Hall needs to watch his back.
Yeah, he's next.
I mean,
Watch out,
I
Uriah.
was also asking somebody, I was like, I know it was Chris Weidman's right leg. Was that the leg that got kicked? Somebody checked that. Was it Anderson? Because Anderson Silva is a southpaw, right?
Sure.
So he probably would have kicked with his left leg on a Chris Weidman's right leg, right?
We'll have to check the tape.
Yeah.
Dr. Conor McGregor was out there tweeting about that. I don't know if you saw that.
Yeah. I actually asked him if he wanted to join. I said, "Thanks, Professor. You want to join me on my next medical breakdown?" He never responded.
Oh man, come on, Dr. Conor.
Come on, man.
Come on, man. Jump on the horn. Not too far off. I mean, actually, for calcium remodeling, what these guys do with shin conditioning, there is microfracturing, obviously.
Oh yeah. Yeah, people were asking me. I think it's absolutely possible he could have had something predisposing.
Sure. It also makes me wonder the age, the demographics, because he's 36 now. I think Anderson was 38 when that happened.
Yeah, for sure.
To see that, because we're starting to draw correlation. Of course, correlation doesn't equal causation, but you start to see patterns and you start to go, I wonder why.
Right.
And we can have conjecture. Obviously, there's not going to be a bunch of peer-reviewed literature on, fighters kicking the other person in the shin and what frequency their tib fib fracture.
Right.
So, docs like him are the ones observing it and coming up with ideas and doing case reports, because there isn't literature. And reach, and shrug, and reach, and shrug. Good. In WWE, you had Sid Vicious when he jumps off the top turnbuckle and his whole leg folds over.
WWE is just brutal, man. Brutal. You ever take care of any of those guys? Brutal way to make a living, man.
Yeah, they're probably harder on their body. The stuff they have is probably more permanent.
Oh yeah.
Their mass is higher. Obviously, they're not getting USADA tested, and
a lot of them are taking some extra help for sure.
Yeah.
A lot of, and the thing. So things about anabolics that people don't understand. Yes, it makes your muscles bigger. But it also weakens your tendons. So those are the patients that I see that have like pec ruptures, bicep ruptures, Achilles ruptures, patellar tendon. So the tendons that get like deranged on that stuff. And I always you can spot them when they walk in.
Well, the theory is that the way the satellite cells work around the muscles is very instantaneous, high blood circulation, but tendons take a lot longer to develop tensile strength. So you get a massive disproportionate.
Yeah.
Even the bone itself takes a long time to be able to be strong enough to hold the tendon on.
Yeah.
And when you jump up 100 pounds eating trenbolone sandwiches on your bench, things come ripping right off.
Yeah, I mean, it's just crazy. It's like you tune in, you're flipping through the channels. It's like Shawn Michaels is still doing it. It's like these guys, it's like, what is he? He's got to be like 45, 50 years old.
Undertaker's
It's maybe
just retired,
60 years
right?
old. I just can't imagine. I mean, that's rough on the body. Like, I don't want to do that.
Well, yeah,
It's
I mean,
like-
people are like, oh, it's fake. But you're still catching a 300-pound
Yeah, the
man
damage
body
is not-
falling on the ground.
The damage is not fake. Man.
Yeah, it's
the
not,
damage
it's
is
not
not
the
fake.
impact of the punch
Yeah.
that's the problem.
Yeah.
It's the jumping off the turnbuckle and landing on your shoulder or your neck. Or,
Yeah. And those guys keep going.
Mm-hmm.
Like they keep going. If you look at like MMA guy, like a UFC fighter versus an NBA guy, can you and you realize the differences of their stop point?
Sure.
I mean, it's like Jerry Cannonier sustains an ulnar fracture on the first kick of the fight versus Whitaker. He fights for 25 minutes, and then somebody sprains their ankle in NBA and they're out immediately. They're limping out. It's just such a massive difference of perspective.
For sure.
And then look how much they're getting compensated too.
Right.
I mean, it's crazy.
It incentivizes you to sit out for 5 weeks until you're
Yeah,
ready.
yeah,
The fighters
yeah.
don't have that option, really.
Right, exactly.
Let's flip over on your stomach. Yeah, we were always talking. Actually, there was another fight that I was ringside on was Legacy, and Holly Holm was fighting for the belt, and she took a leg kick, fractured ulna first round.
Yeah.
And ended up going 4 rounds. She knew her arm was broken right away.
Right.
So then she ended up landing a head kick knockout, and she goes to finish with the hand, and you could see her starting to go with it like that, and then she remembers, and then she switches and starts hitting like that.
Yeah.
So you're feeling it right there.
Yeah.
Big deep breath. And you feel a little pressure there too?
Yeah.
Adjust those ribs. Bring it right there. Big deep breath and blow it out. There we go. Do one more right here. Big deep breath and out. Good. Any different there?
Yeah.
As you can see, Doc had surgery on his elbow. He had a subluxating ulnar nerve. This was flipping over every time he did curls. So that'll shoot down to your pinky and ring finger, and
Get a zing every time you do a curl.
no fun.
Yeah, and when I used to have time to lift weights and look good and stuff,
That's funny. So a good buddy of mine, Alistair Overeem, I think I probably did 11 camps with him. The first time we met him, Greg Jackson brings into my office. He's having some elbow issues, right? And he's like, oh, I've got the guy. He can fix anything. And he comes in. I think the first thing I did was send him to go have surgery. He actually came down here
Yeah.
to Miami to have, he had,
Actually, I was there.
were you?
I was in fellowship. Right?
Okay.
I was in the
2014, 15?
Yep.
Yep, I sent him down. So he had seen a bunch of docs, and they're like,
You
oh,
sent him down here?
Mhm.
Okay.
he was doing push-ups or something, and one of the bone spurs popped free in his elbow and was jammed in there on the ulnar nerve. Yep.
I was in on that.
Which is fairly, so wow, small world, huh? So, his pinky and ring finger were down, and then he had hypothenar wasting, exactly, classic. And he comes in, they're like, can you help me with that? I'm like, yeah, you need surgery, man. Which later he appreciated for, but he's like, no, you can just work on it. I'm like, look, there's nothing I can do for that, my guy. And the longer this goes, the more the nerve damage is going to be permanent.
Yeah. So I was the ringside doc for his fight versus Harris.
Okay.
Yeah. That was actually a really cool moment. That was, Harris was coming back after his tragic thing with his daughter.
Right. So there was no crowd for that, right?
There was no crowd. And it looked like Harris was, going to finish Overeem in the first round.
Mhm.
And Overeem being the pro that he is, he weathered the storm and then came back in the second and, ends up finishing Harris. And Harris was really, very emotional because obviously what he was going through personally.
Right.
And this is actually the coolest moment I've ever been a part of in MMA is I was literally 4 feet away and Overeem leans over him, puts his big arm around him and says, just breathe. It was really cool. It was, I got goosebumps,
Just checking on him, just taking care of your
just
fellow
like,
man.
it's like brother to brother. It's just like, it was human connection.
Yeah.
It's like, I can feel what you're feeling through, you're going through. He was very emotional about his daughter and his first fight back, and he said, just breathe, and let's train together, and it was really cool.
Yeah. And that's the beautiful part of a sport where people are giving each other CTE, right? Is that you have these humanizing moments where people, what do they say? You never know somebody as well as you do if you fight them.
Right.
Which is probably true.
Yeah.
Shared that moment, which is wild.
Yeah.
It's crazy to think.
And when that buzzer sounds, you see nothing but respect. 99% of the time.
Do you still do jiu-jitsu?
You know, I was doing jiu-jitsu, and then during the COVID stuff, I kind of scaled back. And then my wife, you know, was pregnant, so she kind of wanted me to avoid, you know, very close exposure, you know.
Right.
So, but man, now my oldest son is 6, so I put him in all these holds, and he's like, he wants to wrestle and like do jiu-jitsu and stuff.
Were you belted?
Yeah, so I got up to like 4-stripe blue belt.
Okay, so pretty good.
So I probably did it for like 3 or 4 years.
Nice.
And I never cared about the belts. You know, I did it because, you know, it was like fun to like work out.
Yeah.
And it's just like, you know, birds of a feather want to flock together. So
sure.
I talked to my MMA guys, you know.
Mm-hmm. Yeah, I grew up wrestling too.
Yeah.
Actually, I just, you know, one of the rituals in John Jones' camp is he makes all the people that aren't wrestlers wrestle.
There.
So the last video we just had with Phil Fister, I had bruises all over my arm.
Oh, man.
And it's because he had me wrestling his strength conditioning coaches.
Yikes.
Who I'm 10 years older than, and, you know,
Yeah.
they're not going to pass USADA.
Yeah, right.
I still got the takedowns, though.
There you go. What was it? What takedown was it?
I mean, low single on one of them, and then a big, strong guy, so I was setting up a head and arm, so I let him roll me all the way through to create a scramble.
Jiu-jitsu, huh?
Mm-hmm.
So have you done jiu-jitsu?
Then I go north-south. Yeah, some. I mean, I'm in the gym, you know, we've been inside of Jackson Wing since
Yeah, so you're just, like,
2013.
Osmosis.
Yeah, so we get down there and roll around sometimes, and watched a lot of practice, obviously, over the years, and, you know.
Yeah.
My office is right next door to Greg Jackson, so.
Oh, that's cool.
Yeah, right there. Feel tight?
Oh, yeah.
Yeah. All right, so I'm gonna hold that till it starts to fade. Yeah, I remember, shoot, when I was in college. So like I said, I wrestled a lot growing up, but I was pretty decent. But I was unfamiliar with jiu-jitsu, and in the dorms there were some guys that did jiu-jitsu, and they're like, "Let's grapple," and I would always dive in and, you know, shoot a blast double and just get guillotined to kingdom. I'm like, no, do it again, boom, get me again.
Yep. That was the hardest thing about starting jiu-jitsu was
not sticking your head
in my back. I know, I just couldn't.
Oh yeah, that too, right?
It's like you're losing if you're in wrestling. Right. You're on your back, you're losing.
Allowing yourself to go to your back, and then allowing people to be on your back,
right,
as well, because it's a safe position in wrestling, right?
Yeah. And then the intensity is way different too.
Yeah, you're not pushing so hard, right?
The wrestling is a 6-minute sprint.
Yep.
And then I remember my first couple jiu-jitsu classes, they were like, dude, you just gotta like tone it down a little bit. I'm like, what are you talking about? And then, you know, you kind of realize everyone's just kind of a little bit more, you know, goes with the flow.
Mm-hmm. And you can't keep up that pace either, right?
Right.
You can't do that for 15 minutes.
No. And that's how you get injured too.
Yeah. Yeah, some of my first injuries were wrestling. You know,
yeah.
VMO tear.
Oh wow.
Yeah.
Where, at the knee?
Yeah.
Jeez.
Yeah, one of the interesting ones for me is my QF tightness, and I don't know it's my stance or whatever I'm doing treating. My quadratus femoris gets so tight, so then when I'm trying to walk, my stride won't extend because my femur won't get away from my ischium, and I start pinching in the front, whether it's me overstraining with my rectus femoris or it's actually pinching the joint. Mm-hmm. Do you guys do much regenerative type stuff?
I do a lot. I do. So I do a bunch of PRP.
Okay. Particularly knees.
Everywhere. Shoulder, knee. I mean, tennis elbow. You know, my UFC guys actually they get so many. They love it in the ribs. Love it. Love it.
It's constantly torn cartilage, seeing that all the time.
We send out for a lot of those.
So I had a guy. He's in England. He's a UFC guy.
Do you do Prolo ever if the cartilage is pretty torn? Or do you mostly just do PRP?
Mostly PRP, just because it works so damn well.
Right.
And it's readily available. You know, it's their own stuff. You don't have to worry about USADA or any of that kind of stuff. And I'm calling, like, if I have any doubt, I'm calling Jeff Nowitzki.
Right.
Like, I call him like a couple times a month.
Okay.
And he likes it because he's like, you know, I appreciate you asking me.
Yeah.
Because I never want to jeopardize, you know, these guys' careers. And usually I will I'll do it in front of them or something, or just make sure that I want them to know that I want them to know that I'm on it, you know?
Right.
I'm not just cowboying it.
Well, and plus with these guys, you know, obviously the pro is going to cause a lot of inflammation and pain right off the bat,
Yeah.
so that's not necessarily necessary.
Yeah. Oh man.
That's what we run into. I mean, you see them often, and the fear, of course, is non-union. You know?
Right. But man, if you look at an X-ray of a fighter's ribs, it's just disgusting.
Right.
I mean, you don't treat it based on the appearance.
Sure.
So it's like the PRP. You're not expecting to like change that X-ray.
Right.
You're just going to treat the pain, and man, it just works.
Yeah.
You know, it just does. Like I had a guy. He said he was struggling with it for 5 years. You know, he's in the UFC. He's a welterweight.
Uh-huh.
And after his recent win, we did a PRP, and he messages me. He's like, Doc, it's a miracle. It's like I haven't felt this good in 5 years. I mean, I wasn't expecting that.
And like I always tell guys, the risk
bad,
benefit is pretty favorable.
Yeah, there's really not a downside
not a lot of risk.
to it. No. I mean, the blood draw obviously is a blood draw, but it's their own stuff.
Sure. You do like fat or bone marrow stem cells too?
I've done the BMAC, the bone marrow aspiration from the pelvis, and I do the other stuff as well. And some of us, like I used to do it, like if I'm doing like a cartilage procedure in the knee, like I would add bone marrow aspiration and stuff.
Makes sense.
But now we almost feel like it because it's got oh man, you got the spot right there.
Welcome.
Oh, bro. But we feel like, because we're trying to, cartilage is tricky, right? Cartilage is it's like a one-time gift from God. So we try to do our best to try to replicate, real cartilage, but really we just get the scar cartilage, for the most part. So, but we feel like some of the other stuff, like the bone marrow, if you add it turns it wants to sway it more towards like turning into bone.
Bone, yeah, I've heard that.
So the PRP, we think now might be a little bit better.
That makes sense. So I did the embryonic in Colombia on my knee, and pretty, massive condylation patella.
Okay.
Super crepitus. It's been that way for a long time. Especially with that VMO tear and the meniscus tear on that same side.
Yeah.
Kneecap wants to tilt outward.
Okay.
And I've worn a bone away out there too. So they just, let's give it a ride. Yeah. I really went for my ulcerative colitis.
Okay. So you got it intravenously?
Yeah.
Or what? Okay. Man, these hamstrings.
It's bone
So
over
do
and
you
over
feel
again.
something jacked up in that hamstring?
It just your bicep
just
femoris
freaking
is
tight, right?
Locked up.
Man, I
On
feel like
both sides.
this last month it got so tight.
Yeah, so I mean, it's funny because this knee was always worse, and it was crunch, 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 and they went in from the outside there and injected it there. It's significantly less than it was before.
Okay.
It historically hadn't been very painful until maybe the last couple of years, but I've had it since I was, I think I had a cartilage defect from wrestling, from shooting on it when I was 16, 17 years old. I played college football, so I lifted crazy heavy through college, and
Man, I feel like my like legs on fire right now.
It's gonna be a little spicy right here.
So I would say, talking about popping and cracking. So I get patients all the time worried about popping, cracking of their knees or like shoulders and things like that. So I always tell them it's a very common thing that we hear. We don't really worry about it that much.
Sure.
An MRI of a knee that's popping, cracking can be absolutely normal. And so usually it comes down to popping and cracking of the knee is usually like imbalance of the quadricep muscles. And that can cause some sliding of the kneecap within the kneecap groove. And so usually what we recommend, first of all, if it doesn't hurt, we don't worry about it too much. But one thing they can do is try to strengthen their VMOs, or the vastus medialis, one of the quad muscles, and then their quads in general, to try to kind of get some balance and get that knee working biomechanically better.
Sure.
So
eccentric loading.
hear it all the time though, and we don't worry about it. The other thing I hear all the time is, Doc, usually I have a really high pain threshold, right? As I've never heard of someone say they have a low pain threshold.
Right, yeah.
I was gonna say that.
I hear that in my
usually have
eyes,
the
and
worst
my
pain
eyes just start
tolerance
to
and say
roll.
that.
I'm just like,
I know.
it's like,
That's funny.
Yeah.
The things that people take imaginary pride in
yeah.
are always
And now I just tell them,
Cool.
I was like,
pain subjective.
yeah. I was like, oh, really? Because the last patient said
Nobody
the same
knows
thing.
what other people's pain feels like, so
Right.
I find that people that say that usually have worse pain tolerance
Yes.
than the average person, to be honest with you.
Why would somebody say that?
I find that I'm a lot tougher than most
So
people
it's funny
also.
you're talking about MRIs in the knee. So
Yeah.
you'll hear a lot of people just because now we have the anti-MRI age too, right? And the truth is
Right.
always somewhere in the middle. So they'll be like, oh, there's asymptomatic findings and blah 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 blah, or they'll cherry pick the meniscus studies to be
Right.
like, oh, it wasn't better than rehab, and it's like, whoa. Triangulation, this is why we have clinicians, so that
Right.
they can take a look at what the issue is.
Right.
So if I'm going down the stairs and I have anterior knee pain and it's around the patellar ligament, and you do an MRI and I have a medial meniscus tear, and all my orthopedists are negative, there was no trauma,
Right.
then yeah, it probably is a silent one and it's not what
Right.
you would want to treat.
Right.
But if you're grappling or you stick your foot in the ground and
Right.
turn it, it
Right.
pops,
Right.
you have pinpoint tenderness, you're positive McMurray's,
Right.
and you do your MRI, we know that surgery is going to be much more effective.
Right.
So the problem when we're doing these studies is they're not necessarily picking the patient population that would be
Right.
necessary through the clinician
Yeah.
choosing it, right?
Right,
They're
right.
taking people who have MRI tears, some silent, some are symptomatic.
Right.
And they're looking at surgeries in all of them.
Right.
So that's not really that great of data.
Right. Yeah, so if you want to break it down injury-wise, there's wear and tears, and then there's injuries. And so, you know, my antenna goes up in the office if someone had a clear injury, like oh, I was skiing and my knee popped or something like that, and then you look at their knee and there's swelling, you know something's going on. There, you know, there an MRI makes sense, and whatever is structurally torn probably was injured.
Sure.
But then you can have other factors where you definitely always have to match up the history with the exam with the MRI, because if I get an MRI on anybody's knee, I might find a meniscus tear.
Right.
So if the patient has no symptoms, what do you do with that?
Sure.
It's like I always tell people, and patients sometimes come and be like, well, I got this MRI and it showed a meniscus tear.
Right.
It's like, yeah, but it doesn't hurt. So do you have any pain in your knee?
Right.
No.
And if they do, it doesn't fit anatomically with the image.
But sometimes they'll even say like, I have no pain or something, and I say, well, how do I make that better?
Right.
But I can make you worse.
Right.
Sure. So it's like you told me you have no pain. I can't make you better.
Exactly.
There's no, there's nothing I can gain from this.
Well, that's like in our office. We won't treat anybody that doesn't have an issue. If people want to come for like wellness, I'm like, no. There's only one way we can go from here.
Right.
And it's down. It's like you don't have any problem. You shouldn't be here.
Right.
Please go do your stretches, your rehab stuff, and please stay out of our office.
Right.
And like at our office, we average 3 or 4 sessions, and
we
know on visit 1 or 2 if we're going to be able to help them or not,
Yeah.
or if we need to refer them out right away. So, we're not at our office. It's interesting because like a lot of chiro PTs, they have people coming in all the time, and that's just antithetical to our practice. Like if we're going to help you, we'll know within 2 sessions.
Yeah.
If not, we need to pass you on to the right provider.
Yeah.
People appreciate that. So.
Right.
It's very interesting when you take a look at like I said, because before we had everybody who was obsessed with the MRI, because it's really only 30-year-old technology. It's pretty new stuff.
Right.
And this was the end all be all, right? No exam, no history. We're like, oh, this is all there is.
Right.
And now with the rise of the internet and particularly the DPT and some of the DC community too, they cherry pick these studies that show lots of asymptomatic findings on hips and knees and things, and they use that to discredit the use of any MRI at all.
Yeah.
And of course, the truth is always somewhere in the middle, right?
Yeah, for sure.
Radical moderates, right? Like when necessary, let's use our common sense and our logical reasoning.
I'm always a fan of a plain X-ray too.
Yeah.
Because you can miss things if you only come in with an MRI, or if I see a plain X-ray and patient's got arthritis of the knee, I don't care what the MRI shows.
Sure.
I don't care.
Yeah, if it's bone on bone, right?
I can tell you, like if you see
Yeah,
arthritis,
space on the medial
if
side.
you see arthritis on an X-ray, I will bet money you have a meniscus tear. But
Right.
I'm not
Of
treating
course.
that meniscus tear. The arthritis is overlying. So.
Right. So that person may need a partial or.
Right. Yeah. I mean, or it's like now we're not treating this knee as a meniscus tear knee. We're treating it as an arthritic knee. So we have to march down that pathway.
Sure.
But yeah, if you find, sometimes you can find findings on an X-ray where you don't need to get an MRI. It's not really helpful.
Right. Yeah, and some of the stuff you can see on the X-ray, like the anterior fat pad or whatever. Like,
right.
I mean, we'll get it just to confirm, but you've got a sliding. You got a Lockman's. You've got the fat pad signal.
Right.
You're
Right.
sales part.
Right.
So what when you're watching fights, is
Yeah.
there something that you've been able to spot that's more of a pattern? So obviously you're getting boxers fractures
A lot,
and ulnar fractures.
Right.
What are some other MMA specific injuries that you've noted that you see there that you're not seeing as much in
Right.
NBA, NFL?
So a lot of these guys that I see, I would say a lot of them get knee stuff. A lot of knee stuff. And the other thing that folks got to understand is most of the injuries actually occur in training. Okay, and these guys train very intense, and there's some controversy about that. Like you hear about people doing less hard sparring, less, and I think it's kind of smart. You don't want to sustain a lot of damage because then you're on the shelf and you're not earning, and you're not competing. But a lot of these guys get knee stuff, and it's probably a lot of the wrestling, the grappling.
You see a lot of those LCL tears from jiu-jitsu.
A lot of LCL.
Trying to pull that leg up. And
Yep. A lot of LCL. A lot of these guys have meniscus stuff.
Yeah.
Their knees have a lot of stuff going on. So.
Yeah,
A lot of
I would
rib
say
stuff
that
as well, yeah.
what I see is the same thing.
Yeah.
LCL, rib, cartilage tears.
Yeah.
Some fractures,
Yeah.
a lot of calcification there. At least in practice, those are the 2 biggest ones that I see.
Right.
We get some partial hamstring tears and things like
Yeah.
that. So one thing we've been finding with the grade 1 and 2 hamstring tears is dry needling into the extended position.
Like of a muscle belly hamstring. Yeah. So those guys are you seeing a lot of those on these guys?
Yeah.
They're supposed to be flexible. So
Right.
A lot of times it's like, 'cause you're not. Like, I'm the guy that gets the hamstring.
Right.
Because I'm so inflexible. But,
So Marcin Tybura, he was going to fight
Okay.
Fabrizio Verdum, and he had a grade 1 to 2 hamstring
Yeah.
pop about 5 weeks out. and giving yourself an inch on either side of where we believe the tear is, to deactivate the tissue to allow the fibers to glide together
Right.
better.
Right.
Within a week, he was back to throwing high kicks again.
Yeah.
He couldn't create a ton of force with a
Right.
polar eccentric.
Yeah.
So resisting a takedown would be tricky, but most of those guys, it gets fibrotic so quickly because
Right. And
of
those
the
are the ones
pain.
that PRP does very well too.
Yeah,
on
makes
the
sense.
muscle, on
Yeah,
the muscle,
perfect.
on the muscle tears for sure.
Yeah. So, it's interesting. And one of our NFL guys, Kenyon Barner, who's in LA, chronic hamstring issue, couldn't find,
Yeah.
all the docs in LA, everywhere else.
Yeah.
Same thing, moving into a fully extended position
Yeah.
and then using dry needling into that central
Yeah,
area, 2
right.
sessions, gone.
That's great.
Yeah.
Yeah.
And that you would know that if you weren't, having these MMA fighters, particularly guys from
Yeah.
other countries,
Yeah.
if they're like desperate, they're like, "I'll try anything because I'm
Yeah.
gonna have to go back to Russia or Mongolia.
Right.
If I have to pull out of this fight, like whatever, I'll try anything."
Right.
We're like, "Okay, well,
Yeah.
you're gonna have to pull out anyway, so
Right.
let's get a little aggressive on it."
Yeah.
And then you find, new therapeutics
Right.
that way.
Right.
Because again, this is an emerging field. I mean,
Yeah.
at some point, MMA medicine will be its own.
And I'm
branch.
always a fan. I mean, like, we talked about like graduating school. Like, I still feel like I'm a student. Like, you probably still feel like you're a student. Like, the day you stop trying to learn and stop trying to get better is, that's a sad day, and it's not good for your patients. So it's like we're lifelong learners, and you should always be kind of like, 1 foot in comfort, 1 foot in chaos, something
Yeah.
like Jordan Peterson almost. But
Yep.
you got to kind of think outside the box.
Well, and if you're a problem solver, you're always looking for pattern recognition. What are the whys, the hows?
Right.
And is there a correlation? And maybe everything we've always thought might not be right?
Right.
And maybe things
Right.
that have worked in the
Dogmas.
past
Yeah.
work, but not for the reasons why we thought they work.
Right.
So that's something we run into with like acupuncture, dry needle, and chiropractic. Particularly the Eastern medicines. They clearly work for some things, or they wouldn't still be here.
Right.
Yeah,
Yeah, for sure.
In the Eastern medicine, you do a pattern, right?
Yeah.
And you do something on yourself.
Yeah.
And you're like, oh, that's better, and you write it down, and then you try it on somebody else, and you get a pattern.
Right.
But they didn't have underlying, they weren't reading Guyton and Hall, and then or Netters and trying to work
Right.
their way backwards from
Right,
that.
right.
So a lot of times what we do with that kind of stuff is we take it and we try to figure out why does this work, and then using what we know about physiology now, we try to unwind it and then see if we can figure out the actual mechanism,
Right.
and then we can use it on the right and proper
Yeah,
context.
yeah.
Instead of saying, oh, subluxation theory or chi
Right.
or whatever, Eastern philosophies, which again, I'm not discounting them, but if we're going to be precise in the scientific world, we need to be able to communicate in means that make sense in the medical community as well, and have a sound understanding of physiology. Again, in the same context that we talk about, that's listed in the journals. You're not saying chi or subluxation theory, in any kind
Right.
of journal. So it's just not a means to communicate effectively between professions either.
Right.
So I get that beef a lot of times from some of the chiropractors that I know, because I'm, I guess, what we call a reformer mixer or whatever, where I don't treat subluxation complexes, right? We're creating joint motion when necessary and
Right.
trying to restore the proper length tension relationships of muscles. It's ironic with us, when all you have is a hammer, everything looks like a nail.
Right. Exactly. Yeah.
And they're like,
I
well,
would know about that.
right? Yeah, we both would actually.
Yeah, I feel
that's
like
tight.
my low back's been bad.
So feel that one.
Losing that flexibility. Yeah.
Well,
You know what? I think I have a labral tear on that side.
yeah.
But I just ignore it.
So there's hamstring, right?
Yeah.
That's QF right there.
Yeah.
So when you get a high hamstring pull and you stretch it and roll it, do eccentric loading and everything else, and it doesn't work, a lot of times that quadratus femoris, because it
Yeah.
attaches on the ischium, is actually the problem. So for me, what I'll do with this one is I'll just pick my knee up and I'll use a massage gun right along there, and usually that clears it out.
Ooh. Yeah.
And this one gives me fits from standing like this all day. So I'm assuming you can have the same one right there.
I only stand up at work.
Yeah, with slight bending forward, right?
Yeah.
And then looking up a little bit.
Yeah. Well,
Yeah.
I'm in the office. Yeah, I'm standing up. I'm doing notes.
Yeah.
I'll go in a patient room and sit down, for a minute. But
Yeah.
when I'm operating, I'm standing up.
Yeah, I treat a lot of surgeons.
Yeah.
We're right next to 2 of the hospitals, so I think we have about 55 physicians that
Wow.
come in to see us.
All kinds.
Yeah, all kinds. So
Any orthos?
yeah,
Nice.
yeah,
Sports guys?
some.
Yeah.
Yeah, we have a couple of neurosurgeons that come in. There's not a ton of them in our town, obviously. We only
Yeah.
have 400,000 people, but
That's not small.
the big dogs at the hospitals, the cardiologists,
Uh-huh.
and the neurosurgeons. We work with a lot of them,
Mhm.
and they know when and what to refer to, which is nice.
Yeah.
And yeah, even quite a few ER.
Yeah, ER docs.
Yeah, which is funny because given my profession, that's unexpected.
Yeah. No, I'm glad to hear that actually, that they come to see you, because I feel like we get so busy and caught up helping other people.
Right, you don't take
we don't
care of
take
yourself.
any time in. No. Like I took a vacation last week. I mean, like I had not taken a vacation the whole year. I mean, like my dad passed away this last year.
I'm sorry.
And I took 10 days for that, and that was it for a year. So I was just like, I was just getting run into the ground.
So check out this tone now. You're not kicking me anymore.
Better.
It's not shooting back out.
So you can start coming out here every week now, right?
I'm a little bit expensive,
come
man.
over, right?
I'm a little bit expensive. You're a big dog. I'm sure you're making plenty of money, but I'm a little bit expensive.
Yeah.
So even when I throw it, see how it's not shooting back anymore?
Yeah.
So that QF extra
Yeah,
rotator,
literally.
right?
It was like spring loaded.
Like kicking you, man.
Yeah, no, I've been feeling really tight, yeah.
Let's see if this one is. Yeah, not as bad.
Right.
Not nearly as bad. Look at that.
Papalides was tight.
I
that
was
one.
stretching out this morning. I did my 5 a.m. workout, did my run, and I did my Bowflex.
Time to go to bed, man.
Oh,
You're 9
yeah,
o'clock,
I'm
10 o'clock
asleep,
guy?
bro. Yeah, I'm a 10 o'clock guy.
Yeah.
Definitely.
So this, you have like a massage gun?
No,
I can get you one.
I gotta get one. Yeah.
Yeah, this spot right here is probably a chronic one on you.
Yeah.
So if you would basically pick your right knee up like that and then get right between the
Yeah.
trochanter and the ischium.
Yeah. Have my kids do it to me.
There you go.
They'll love it.
Yeah, that's cleared now. So it doesn't hurt anymore.
Yeah, I feel better.
There's a little bit still right there. Yeah.
Mm-hmm.
It's funny. We read a lot of the same books. You're looking at your bookshelf.
I've read every single one of those books.
Yeah.
You know, I think
I have
it's
a majority of them as well. So we have a similar.
I think I read those. Yeah, I think I read all those like literally in the last like 3 years.
Yeah.
And I haven't read that much this last year. It's good. It's good to read. It's good to be a reader, because I feel like, you know, that readers are leaders, and you know, it's like you almost have access to like these geniuses like Benjamin Franklin's and Einstein's and Steve Jobs. Like, yeah, you're not with them, but you can learn. You can read about them. You can learn about them, and then you can get better. You can grow. I think reading is really important.
Was it Ralph Waldo Emerson said every man is my superior in some way, and that I can learn from him?
Absolutely, 100%.
Just a little SI joint mobilization. I'm gonna you roll on your side facing towards me.
Okay.
That. Just cross right there. So
You're gonna hear some violent stuff here.
big deep breath. There we go. Good.
That felt good.
And then sending that this way. Violent.
That felt good.
Got the SI and the L5 set. There we go. Still alive, huh?
Yeah. No, that felt great.
Good. All right, bring that left knee up. And then take it straight back down. And then back up. Yeah, it's not too bad.
Feeling rectus there?
Yeah, rectus abdominis primarily. Back up. So a lot of people will think they're clearing psoas here,
Yeah. Oh.
which is posterior to your intestines.
Yeah.
So that wouldn't be a good
It's
thing.
a little bit lower than that.
Yeah. Well, and you know, if you're picking your knee up, your rectus abdominis is engaging.
Yeah.
So, well, that's why we have you engage it here. A lot of these other areas, I'm pinning the muscle to the bone.
Right.
So that I'm getting it to release that way. Since you don't have a bone there, I've got to have you do active
Yeah.
motion. So that's how the active release kicks in. Same thing here. Right side up, and then back down, and back up. Moving a little transverse colon material. And back down, and back up, and down. Good. And have you pull the elbow straight back. Just go ahead and pull pretty hard. Good. And then same thing here. So it was AC on that side. Pull. It's hot on that one. I'm going to do this upper thoracic spot too.
Okay.
And I'm going to have you go both hands right here. So
Here we go.
there. Big deep breath. And blow it out. Pretty good on it actually. All right, let's go in and out like that. I'm going to get your subscap.
Okay.
I know that's going to be tight from holding your elbows in tight. Is that tickle or?
Yeah, I'm really.
Just give me some of this funky dance move like that.
All right.
And then your Instagram channel, you put a lot of your clips up there too, right?
I do.
And what's your Instagram?
Dr. David Abbasi.
So make sure to go follow him.
Thank you.
You got a TikTok?
I'm on TikTok as well.
He's TikToking also, so go follow him on there.
Yes.
But really,
It's
just go
just-
subscribe to the YouTube channel. He needs that
Yeah.
YouTube love. If you really want to get the in-depth, nuance and really learn about these injuries, the platform, the programming on YouTube is just going to be the best on this. he'll grab your attention on TikTok, but if you really want to understand these injuries,
Yeah.
YouTube's where it's at.
So and honestly, since I've been focusing on that, I feel like that one's been growing the most.
Makes sense.
And so my channel is a lot of like sports injury breakdowns. It's, I'm very MMA weighted, but
I saw some NFL stuff
I
too,
do some.
right?
I'll do some
NBA.
NFL. I'll do NBA on the major injuries because I just love talking about the sports medicine aspect
Sure.
of it. And then I'm also, I've been posting like my actual orthopedic surgery stuff. So you can like watch me operate on a knee or operate on a shoulder. Actually, you can watch me watch. I have Phil DeRue's surgery online. It's on his channel.
Okay.
So you can watch my
His
like
knee surgery?
consultation. Yeah.
Wow. I think I've seen some of that actually. now
Yeah.
that you said
So
that.
yeah.
Yeah. So shake that out and see how that feels.
Yeah. Feels
Yeah.
good.
Yeah. Neck to looser too.
Yeah.
And then arms.
Wow. Yeah. That feels really. I feel really good. I feel like really like loose right now.
There you go.
I never feel loose. I never feel.
You never take care of yourself. I'm gonna get a little lower lat too here
Okay.
since we're at this. So let's go here and we're just gonna go up and down. I'm gonna clear this lower aspect of the lat. So like a shoulder press. So up all the way. Raise the roof.
So I was a wrestler. Can you tell?
Yeah.
What my lats are?
Yeah.
I mean, I don't work them out that much.
But it's
I used to be a beast on the pull-up bar, man.
I could see that.
Beast.
Every time when you're in Miami, you gotta raise the roof.
That's right.
Raise the roof. Hey, hey, said raise the roof. Hey, hey. Uncle Luke. We're showing my age.
You're a young man.
Oh, we're the same age?
I'm just a year older than you.
Okay. I thought we were the same age. Same thing on this side. So you're the young man in your field. I mean, we both are.
I try.
In healthcare in general, like, you expect a doctor to be in their 60s, right? So,
Yeah, I guess.
yeah. Well, so I mean, I did 2 doctorates. So my first one, chiropractic, it's a 4-year. We don't do a residency, obviously. But you're in practice,
Right.
4 years undergrad, 4 years grad
Right.
school. You're out at 26.
Yeah, right. So I've been in practice now for about almost 7 years. So it's like, yeah, I'm still, I guess you would consider me young, but
Right.
7 years is not,
It's a good amount.
good amount of experience. And I'm very busy though.
Right.
So I see a lot of people,
Well, and then you were, even in your residency, you were
Right.
doing the,
Yeah.
you're practicing medicine, so it's not like you weren't in practice. You were just
Right.
supervised and learning the game.
Right.
There we go. Yeah, I was saying I just finished my second doctorate in 2017, so that was 15 years straight of college.
Yeah.
Because I did a master's in exercise sci after the first doctorate,
Right.
and I did the second doctorate after
Yeah.
that. So I was like, yeah, collecting degrees like Pokemon cards.
Yeah. It's good. Education's a good thing,
Well, like I always tell people, like, well, why'd you get a naturopathy degree? And I said, I felt, as a manual therapist, again, there isn't one tool that fixes all, so you need other lenses to look through.
Right.
And I value that. That's why I did the master's in exercise sci too. So, you're looking at other things that could be contributing, particularly from a rehab perspective.
Right.
So yes, you might have a skill set, but if you don't have another lens to look at, you might be A, missing something that you could fix, or B, you're not getting them into the right clinician,
Right.
So that was big for me.
Yeah.
Awesome. So you feel pretty good?
Feel great.
Awesome, man. So guys,
Thank
make
you.
sure to go sub to his YouTube channel, check out his Instagram, website. If people need to book appointments with you.
Oh yeah, orthopedics, OCPBC.com. I'm down in South Florida.
So if people in South Florida, if you guys need, if
Yeah.
you got something really wrong, you need a doctor to look at, or if you're looking for somebody who's doing PRP, doc up here can
Right.
take good care of you.
Yeah, appreciate it.
Yeah. Oh yeah, one aside.
Yeah.
So I know you guys are giving me crap. You're like, oh, I don't want to hear a chiropractor talk about the vaccine. Let's take it from a real doctor here and let you know what he thinks about the vaccine. You're fully vaccinated.
I'm
Yeah?
vaccinated. My wife, she's 6 months pregnant. We were hesitant to do her, but we ended up talking to the OB, and the results show that she was better off getting vaccinated. So my wife is vaccinated as well. Yeah, I think it's very important. There's been a lot of studies done now. We have millions of patients, and it shows that basically getting vaccinated, if you were to catch coronavirus, you would have much less severe symptoms. And so we go with the science.
Absolutely.
Yeah.
And I've been fully vaccinated for almost 4 months now. Still haven't got any superpowers or anything like that. I'm hoping for maybe some X-ray vision or something. But guys, really important, if we're going to get our society back, if we're going to protect people, make sure you guys get out there and get it done.
Absolutely.